networks. I am also the project lead for reducing hospitalizations, readmissions, and ER visits. Next slide, please. Stephanie, if possible, I hope that you've hit record.
I did.
Thank you. So for today's agenda, we're going to go over some meeting minders. We're going to go talk about the hospitalization project. We're going to have our guest speaker speak, and then the same agenda items will follow for vaccinations. Next slide. So the meeting minders are the usual. Please mute your line if you're not speaking to avoid background noise. We ask that you do not open up your microphone, and if you have any questions or feedback, please place them in the chat and those will be forwarded to our speakers. Please be present and engaged and think about how these interventions could be expanded into use in your facility. Please make sure that you are putting those questions in chat and addressing the comments to everyone, not a single person. And all of the materials are available on IPRO Learn or the network program website that may be referenced during the course of this presentation. Next slide. So the objectives of this presentation are as follows. We're going to talk about the goals for hospitalization and hospitalization reduction for COVID. We're going to talk about the goals for the COVID-19 influenza and pneumococcal vaccine. We're going to talk about how you could promote infection control measures in your facility. And then we're going to talk about bidirectional communication between care providers to assure quality patient care and to reduce hospitalizations. Next slide. So we're going to kick the top of the hour off here with the hospitalization materials. Once again, the goal of this project is to reduce all instances of hospitalizations, readmissions, and ER visits in Medicare fee-for-service patients. Next slide. So every quarter or every 6 months now, we enroll a group of facilities in our QIA project, and all of those facilities are asked to do a root cause analysis to determine what is the underlying issue and causal factor for their hospitalization visits. After many goes on this data, we have found that the percentages are pretty consistent from coalition to coalition, with poor communication between acute care hospitals and dialysis facilities following frequent flyers and mistreatments. We've done multiple interventions with frequent flyers in IPRO Learn, and in the toolkit there are resources, and we've done interventions regarding mistreatments as well. And I think that both of our, most of the facilities that have been enrolled in community coalitions have found a way to decrease those two populations from going to the hospital. But one of the things that we've really found is it's very hard to establish care communication between acute care hospitals and dialysis facilities. Next slide. Next slide, please. So what we've learned after doing technical assistance calls with both low and high performers is that this communication between the hospitals is very difficult, but it's even more prominent in patients who are determined rural or with facilities who are identified as rural. And some of the reasons that it's more difficult communicating with hospitals for these facilities is because the hospitals are many miles away. There is much more difficulty to get access to patients when they aren't treated locally. And the nephrologists that might see them in one community don't have privileges or established relationships with the admitting hospital, and it's very difficult to ascertain what has happened and what is the follow-up to follow a hospitalization. Next slide, please. So just to give you an idea of the impact of rural facilities in the 4 networks, each of the 4 networks, the first column after the network here is the amount of facilities in the network, and then the facilities that work with rural patients, and then the percentages of facilities with rural patients. And the far right box is how many patients there are in each network that are identified as rural by CMS scientists zip code codes. So you can see that there's a significant amount of patients that we can impact on a regular basis to decrease hospitalizations with, but there's also a big amount of promise in the spread of how rural facilities work with these hospitals and patients to decrease hospitalizations to spread to the other facilities. Next slide. So our best practice clinic comes to us today because, as you may know, last month in January, we published a release in our announcements in IPRO Learn of best practice clinics, and we reviewed all of the clinics in each network to determine 3 facilities in each network that were truly best practice facilities. And when I reached out to each one of those facilities after I looked at the data, I found some really significant work with some of these rural facilities. And the person who's going to speak with us today represents a facility in Maine, and I'm going to let her tell you a little bit about that. But over the course of from May, when the project started, through December, this facility had 2 hospitalizations, with their rate of hospitalizations in Medicare fee-for-service patients both below the national average and below the network average. And I'm not lying when I tell you that is a great, great achievement. They had 0 readmissions and 0 ER visits during those 7 months. So if I can ask you to move the slide, Stephanie. Our best practice speaker today is Lorna Voiture. She is an RN. She is from DCI Skowhegan in Maine, and I am going to turn the presentation over to Lorna now. Thank you, Lorna.
You're welcome. Thank you, Deborah. Hello, everybody. I'll tell you a little bit about where I live and how small our clinic is and the people that we impact. As you can see on the slide, our population of the community is about 9,000 patients. I'm sorry, 9,000 people. And it's very rural, a lot of farmland around here. Most of our patients do live in their own homes, some of them alone. We have only 1 person that stays in a nursing home right now. Our hospital in our local town does not provide dialysis. They will send people out that need dialysis. They will send them either to Bangor, which is approximately 70 miles away, or Augusta, which is about 70 miles away. Lewiston, you keep going out further, 90 miles. Portland, I even had a patient that was in New Hampshire recently. The hospitals around here fill up very quickly. And so if you have a patient that needs, sometimes they stay in a hospital until they can be transferred. So it's not like they can just be admitted to a hospital overnight. It's a little bit of a trick getting them where they need to be. All right, most of these patients actually need transportation service. And I have people that have come as far as Jackman, which is about an hour and a half one way. I have a man right now that's actually visiting Moosehead Lake, and he's traveling 2 hours to come here, 2 hours one way. So it's 4 hours both ways for this patient. So that pretty much consumes his whole day. I have a 12-station unit. At the time of the information that was collected, I had 48 patients. We were full, and we actually had a waiting list at that time that probably had a good 5 to 6 patients waiting to start dialysis. We are open Monday through Saturday. We open at 4:45. We close when we close. Of course, everybody And this network knows a lot of times we get snow, and that's another barrier for our patients making it to treatment and to the hospital as well. One of our key tricks is most of our patients do have PCPs. The PCP is the center of their care holistically. So any of the problems we have with those patients, we are in contact with the PCP so we can approach it from a multifaceted way. I would say right now, about 90% of our patients do have a PCP. So the trick that I have found for reducing hospitalizations or preventing readmissions is you got to build a trust with the patient's family, with.
Can I interrupt? Can we move the slide?
Oh, sorry.
Yeah, you're gonna have to tell her to move the slide. I'm sorry.
Okay, I'm sorry.
That's okay, darling.
All right. So our biggest thing, I think, at this clinic is our trust, which comes from communication. Communicate with the patient, communicate with the family. Our staff here in Skowhegan are wonderful. We all are on the same page. We have a communication book. So if you're off for a few days or a week, you can come back and read every single day of what has happened with our patients. We always make sure before a patient is discharged that we advocate for that patient because we know those patients inside and out. We see them sometimes more than their family does. So we call the hospitals and we call the nursing homes and we call their PCP and we make sure that we're all taking care of this patient with the same outlooks. All right. And of course, whenever the patient gets discharged from the hospital and they have their follow-up plan, we try to review it as soon as we can. Hopefully the day they're discharged, the next time they come to treatment, we have their discharge summary, we have their med changes, we have pretty much all of the information that we should need what's going on with the patient. And we make sure that the patient keeps their follow-up appointments with whoever and whatever they were seen for their problem of being admitted to the hospital. All right. If you could change the slide, please. Thank you. So I believe, and I think most of us in dialysis know, that trust is the biggest stepping stone of our careers. I mean, these patients trust you. Even when they go to visit another clinic, they have a little bit of a hard time because they're so used to with the same people all the time. So if that patient is not in control of all of their aspects of their life, I love to talk to their caregivers, their spouses, their children, the nursing home, whoever those people have listed as their next of kin or who they want us to call or who the people I normally speak with. My social worker is wonderful about finding out if they have any other social workers out there. A lot of our patients do have other social workers that help them just in their life in general in trying to maintain them with their appointments and in places to live and groceries and everything. It can be very trying for some patients. I think another big part is the primary care physicians. We need to be in touch with them so they know that these are dialysis patients and they have a very different and special need when it comes to certain areas of their care. And I know the EMS people too. So the EMS and the emergency people are they're very familiar with us. We usually have the same people. That's also good about being in a rural area. Most people know each other. The people at the hospital, at the ER, there's not a lot of changeover, so we know them as well. And the nursing homes. I mean, like I said, right now I only have one patient in a nursing home, but you always have to have and should have a contact there in case you have a problem. You can connect with this person and say, hey, I want to talk about so-and-so and just want to let you know what's going on here. And they're usually very, very receptive to that. All right, if you don't mind changing the slide, please. All right. So with the nursing homes, what we do is we kind of go through a lot of their labs, a lot of the care of their access and the medications that we provide here that are pretty much strictly dialysis patient medications, like your vitamin D and your ESAs and everything, binders, of course. It's always really good to do if you can and you have the time. I have a wonderful educator, and we have actually gone to our nursing homes and we have given some education to them and told them and talked to them about our accesses and what to look for and what not to touch. We like to review with them that we are giving them ESAs. I had a nurse one time from a nursing home, and she called me and said, I need to give this Aranesp. And I said, you don't. And she was like, but you don't understand, it's on my MIR. I explained to her that that was a dialysis medication, and if she gave it and I gave it, the person would be in trouble. So it's kind of like an education with our, our specialized field, which is just, a one-of-a-kind field, in my opinion. We also, the primary care physicians pretty much know most of the time if their patients have kidney problems. It's usually the PCP that refers these patients when they see a creatinine, spike up, or, the person's a long-time diabetic and they just know that they will need dialysis maybe in the future. So our PCPs around here are very, very good at making a referral to nephrology, when they do see these signs of, going to stage 3 and stage 4 kidney failure. So the good thing is if you teach your patients from day one when they come in why their cases are special. Some patients have a hard time with phosphorus. Some people have a hard time with potassium, fluid. There's so many different things in different areas of the patient that you really want the patient to understand if they have a problem, what to look for and who to contact. All right, so we do constantly educate our patients about their labs. I think if you want to know something about a patient, ask them. Most of the times they really do know. All right, if you don't mind changing the slide. Thank you. All right, so whenever a patient is in the hospital and we kind of, like I said, we know our patients and we know their limitations and we know where they live and we know their whole support. So what we do is we call them, if we have a patient that has been in the hospital for quite a while and we know they've been in there for a pretty debilitating reason, we want to call and we'll get a call from the hospital that they're being discharged. Okay, well, I know in the back of my mind that this person is in a wheelchair before they even were hospitalized. This person they live alone. And what is the plan? So I will call the patient in the hospital and ask them, do you know you're being discharged? Most of the time they will say yes. If they don't, I'll ask them if they feel comfortable going home. Can they get up? Can they get into a wheelchair? Can they use a walker? Can they get to the bathroom? So these are the things that will make these people go home. They fall, God forbid something happens to them and they pass away, but if not, they're clearly probably going to end up back in the hospital again with a readmission within the next couple of days because they just were not strong enough to go home by themselves. So what we do is we call them, we talk to the care managers and the discharge planners, our nephrologists, if they're in the hospital where our doctors are, and the patient and the patient's family members. So we kind of make it, a big picture for everybody to make sure everybody's on the same page. And if we don't feel they're ready to come home, then we will express that. And we tell the patients and their family members to please tell that before they are discharged, saying, I do not feel comfortable with my father going home. He can hardly stand. I don't know how I'm going to take care of him. Then usually they'll find them a rehabilitation to go to, and so they can have a safe discharge and not fall, get hurt, or end up right back into the hospital again. Let me see. And our staff as well. It's not just me, it's a team. So every single person that works in this building with me they know our patients. We have the communication book, and if I'm not here and they're being discharged, they will read and find out what's going on, and they will make the call to the hospital or to the patient or all of the above. Okay, next
slide.
Yes, please. All right, so I think I just kind of talked about the advocacy that we do for our patients. And I have to say, in the last year and a half, 2 years, this has become a very big part of our job. Our patients that go into the hospital are very sick. That's why they're in the hospital. It's usually not just for, like anemia or falls is a big thing. So we do a lot of education with falls and safety and walkers and canes and everything that the patient really needs to know and the family member really needs to know as well. So I was going to move into a couple of case studies of a couple of patients that I had here and how we managed to keep these people out of the hospital. All right.
Next slide.
Yep, first slide. So my first slide is case study. He was a patient here a couple of times. He was a 49-year-old white male. He lived at home with his wife and his son. He had a transplant. He had Schwann purpura when he was 17, turned into kidney failure. His father gave him a kidney. He had it for 17 years. So I don't even know if he was on dialysis before he got that transplant, but that HSP can come on rather quickly. So this was a surprise to him. He probably started dialysis. He got the transplant. He did great for 17 years. 17 years later, he came and he was admitted to my clinic. The first time he was admitted, it was his first dialysis admission with me. He was very independent. He drove himself to and from the treatments. He was able to provide most of the information regarding his health and medication and any problems he had. He could review like his current medications. He knew his treatment. He knew his body. Great. Well, then he got a second transplant. All right, so he was gone for a couple of years, and then he was admitted again. This time on his second admission, he was codependent. His family drove him to and from dialysis. His wife really was wonderful, and she worked closely with us in every single aspect of his care, because at that time he just had been on the anti-rejection medications that he took. He did not do well with them. The tacrolimus, for one, really gave him a lot of twitches. He didn't feel safe standing up, walking. So his wife, who also was a nurse, was, a key player in all of his treatment. So let me just give you a little bit of the history for him. Okay, so he started his first round of dialysis with me on December 16th, 2014, was transplanted a little, less than a year later, probably 6 months, on May 11th, 2015. He came back to me again, so that kidney did not last very long. He had it for a little over a year and a half, and he started his second round of dialysis with me on December 3rd, 2016. All right. His dialysis discharge date was 3/28/22. Okay, so the patient's last hospitalization was 3/16/2021. So he was on dialysis the second time for 5 years and about almost 4 months. The hospitalizations he had in those 5 years was 4. Of course, one of them was very unavoidable because he had fallen at home and he had a subdural hematoma. So, that's a no-brainer. He had to go. He was in the hospital for about 13 days. But the other hospitalizations that he had were, one of them was nausea, vomiting, and a couple of them were for his ascites. So the patient had something going on with his liver. They hadn't really diagnosed him with liver failure, but he held all of his fluid in his abdomen. So what we did is we set up a routine appointment with paracentesis. So he could go when we felt we could not get the fluid off of him at dialysis. He had a standing order to go and have paracentesis whenever he needed it. Sometimes it was once a month. Sometimes it was twice a month. Sometimes he could go for a couple of months. So, years and years after this, he was developing a lot of scar tissue. So they were unable to find viable pockets to tap and drain. At that point, the patient said, I'm done. It hurts. They never get anything off. And it really is a lot on me. He did not want to go to the hospital anymore. So then our wonderful social worker we came up with a plan to start some patients on palliative care. People think palliative care are for people who are dying. No, it is not. Palliative care is to help a patient remain comfortable, hopefully in their own home, so they can avoid these hospitalizations. So in that last year of this patient's life, he did not go to the hospital for an entire year because palliative care was set up. He had a hospital bed, he had his pain meds. It was wonderful. When the patient got to a point where dialysis was too much for him, he signed off treatment and he did pass away with his family at his side. So I feel rather than this patient be in the hospital over and over and over for pain control, he was able to be home and controlled. So I thought that was really great because usually patients, he was diagnosed with liver failure in the last like 2 months of his life, which, you know, we kind of had a feeling, but they weren't really completely sure about it. So, all right, now my second case study that I chose was a 77, sorry, thank you for changing the slide, 77-year-old white male. He lived about 30 minutes from the clinic. And sometimes, you know, if it's snow, it's like an hour. It's just according to. He drove himself to and from dialysis. He had a partner for many, many years, and she resided in the same town, but she had her own house. This patient maintained both of their houses, and she had advanced dementia, and he was her sole caregiver at that time. So this man had a lot of stress on him, right? So I'm going to let you know that his dialysis was started in March of 2019. He first started as acute tubular necrosis because he had long-standing Crohn's disease. He has had Crohn's disease since 1968, which happens to be the year I was born, so that's 54 years. That's a long time. His dialysis discharge date was 1/12/23. He was on dialysis just short of 4 years, and he was hospitalized once. His hospitalization was because he had had enough. He signed off. He went on to hospice in the hospital. So the only hospitalization this man had was to stop dialysis and have hospice. And all right, so this patient with his Crohn's disease, he could pretty much not take any medication that we offered. He did in the beginning, and his Crohn's disease, he would tell us it runs his life. So he was unable to tolerate any of the ESAs, and he could not take any IV iron as well. So I think the success in limiting his hospitalizations or omitting all was that we had an idea to call the local hospital. We cannot give blood in my unit because we are not supplied with blood. It's a very rural community. Nobody felt comfortable supplying us with blood. So our patients will have to go elsewhere to a hospital to get any kind of blood transfusion. So this patient, we knew his hemoglobin was always going to be terrible because he could not take Epogen, Aranesp, Mercier, or whatever. He could not handle that. So what we did is we had a standing order that one of our practitioners came up with to transfuse this patient 1 unit of packed red blood cells when his hemoglobin was less than 9 and or the patient was symptomatic. It worked out very well. We didn't have to go through a bunch of rigmarole. All we had to do is call the infusion clinic at the hospital, say, hey, so-and-so is ready for another unit. You ready? They would give us, you know, a day and a time. The patient would come. He'd be typed and crossed on the way into dialysis. After dialysis, he'd leave and he'd go get his unit of blood. It worked out very well to keep this man out of the hospital. And I do believe that is all I have. If anybody has any questions for me, I'll be happy to answer them.
Lorna, this is Debbie, and I can't thank you enough. I think that your advocacy and your creative ideas to bypass the hospital is very promising, and working with the patients and families directly and coming up with creative interventions like
Yes.
palliative care, hospice care, transfusions in a transfusion clinic. You did get 2 compliments for incredible recommendations, and thank you so much. And one question arose, and I think that was when you were talking about your communication book, They
Oh,
asked if your communication book was electronic or if it was a written document.
it is a notebook that we keep locked at the nurse's station. In the morning when we come in, we unlock it, the book is right there. So what we will do is at the end of the day or during the day, if you have time, I know a lot of times you don't in dialysis, we will go through every single patient and write down anything like this patient was clotted, they're having a declot tomorrow. This patient had a fall at home. So we can come in and people might be gone for 2, 3, 4 days a week, and they'll be able to read from the day they left and see what was going on with our patients. And it makes it so much easier because in a huddle sometimes you don't catch everything.
I love that it's old school and it's written like we used to do in the olden days. That's great.
Well, if your computer system's down, you really can't read it,
So somebody asked a question just now. Do you have any suggestions when you have a patient who refuses to get blood transfusions for low hemoglobin and myeloma?
Okay.
That's a different
Actually,
kind of question entirely. Yeah, that's a hard one.
I get it because I did have a couple of patients too that were Jehovah's Witnesses, and they would not get blood. And I would, their goals are different and they had to know that. So I would, it's not like they're going to, I did get them to take an ESA, but of course that's not a human blood product. So I think education about why they're anemic, why they have so many different factors of anemia, their red blood cells don't live as long, their reticulocytes, they lose blood every treatment, and of course with the porcine heparin, one did take the pork heparin and the other one wouldn't. So there's a whole bunch of different areas that I would just sit down and talk to the patient and tell them, okay, you're going to be anemic forever because you're not going to get blood unless you put some of your blood aside. And of course, they didn't have enough blood to put aside. So I would just educate them in a different way and let them know that this is what I'm going to expect and what could I do ahead of time to help them. Well, the good thing is one of them, her kidneys recovered. So I was able to say goodbye and she's living her life, which is wonderful. And the other one moved away. So I have no idea what happened with her. So I just give them a whole different kind of education.
Thank you so much.
Yeah, it's according to the reason why they're not taking the blood. Is it because their lack of education or is it a religious belief? So there's just different, avenues to take when it's a different person. So
I can't say it enough, but I really do appreciate your fresh ideas and your willingness to develop individual interventions for your patient, because as we know, in the long run, those are the ones that are going to be sticking with the patient and they'll be able to follow.
yeah.
So without further ado, I don't see any other questions.
Okay. I want to thank you for giving me the opportunity to speak today. And I just want to say one more thing. I could not do this without my team, my techs, my machine techs, my social worker, dietitian, administrator, educator, my secretary. Everybody has a part. And if everybody works together, it can be very, very rewarding in the end. Thank you so much.
Thank you. It's been a pleasure.
Thank
So
you.
without further ado, I'm going to turn this presentation over to Aisha Edmondson, who's our contract manager that leads COVID hospitalization reduction and vaccination. Aisha?
Thanks, Deb. Good afternoon. As Deb said, my name is Aisha Edmondson, and I am the project lead for vaccinations, as well as COVID hospitalization reduction quality improvement activities. Next slide, please. As facilities, you all have encountered various barriers related to getting patients vaccinated. Through technical assistance and the PDSA cycle with our community coalition facilities, the most frequently discussed vaccine barriers communicated were lack of knowledge, patients not knowing how the lack of vaccines impacted them. And as being an ESRD patient, fear based off previous vaccination history or word of mouth, accessibility, not being able to go get vaccines that aren't offered in clinic due to transportation reasons or scheduling, mistrust in the healthcare system. Many patients have experienced medical racism or other health inequalities, which built up that just not trusting what's going on, not believing the information, things of that nature, as well as vaccine hesitancy, of course, COVID fatigue due to various vaccines and boosters related to COVID-19, and lack of infection control from patients at home, unknown exposures, or no longer doing those preventative measures that they once were doing when they're around their family, friends, or just even in their community. Next slide, please. So as a network, our job is to think about ways to break those barriers. So breaking barriers, ways to break those barriers come in different scenarios, such as helping make their vaccinations happen. Often offer to help make their vaccination appointments if available, if not available at the clinic, helping with transportation, finding other ways to make them feel committed and comfortable when it comes to getting their vaccines, being patient and following up. Changing someone's mind will likely not happen in one conversation. So it may take several, and it may take several follow-ups, but just to kind of check in with those patients and see if they have any new thoughts related to vaccines. And if in some cases, if they're still hesitant, preventing infection comes in different forms, such as reminding them to wash their hands. Hand washing is very important, continuing to wear their mask, and also testing if they feel symptomatic is really important when it comes to exposures and spread of infections, and helping them understand why it's important for them. Being part of an immune compromised community could mean life or death in these situations. So some of these infections can take them to places that they don't want to go and have experiences that they don't want to experience. But again, they may not know that because they're not aware of that information. And again, education. That comes in different ways. That comes in letting patients know, what situations they put themselves in every time they come into the facility, the people that they interact with within the clinic, outside of the clinic, family, just various different ways. Letting them know why vaccines are important to them are the most important part when we talk about vaccinations. Next slide, please. And just ways that other patients in the facility can help. Think about how PFRs can help in these efforts. They can help by helping patients receive information through sharing resources and information that's provided to them, to act as a member of the quality improvement team. They can assist with letting your facility project lead know about any concerns or issues they encounter while they're working with patients. They can also help by handing out materials and sharing information provided by the network. They can help with developing bulletin boards to educate patients, as well as participating in lobby days. Next slide, please. And again, communication. Simple things as getting back to the basics. Proper hand washing and sanitation guides are available. They're useful. You can get all these tools listed on this slide in IPRO Learn. Just making sure that everybody's aware of what's going on around them, their surroundings, and how if vaccines may not be the way to go at this moment, preventative measures are always the way to go. Next slide, please. And here are a few best practice tips that were provided to the network within the network service area. One facility stated, "We always offer our vaccines on admissions. If patients state that they received them elsewhere, we try to track down their vaccination history. We spend a lot of time establishing relationships with our patients. They trust us. They make it more personable so that when those conversations are had, they receive the buy-in from the patients. We give out handouts and talk to the patients about the benefits. We also communicate with the nursing homes and let them know we will be giving the vaccines at the clinic, and we'll send them the information afterwards so that they can also document the vaccines received. Patients' vaccinations are reviewed on admissions and offered at the time of admissions and during 30-day, 90-day annual plans of care. And they also strongly recommend the MD being a part of this process. The MD strongly encourages vaccinations based off the ESRD immune compromised status and the potential. We talked about the potential and the risk to patients. Next slide, please. So here's where I would usually turn it over to my speaker, but unfortunately, I just received a call that due to an unforeseen event at the center, they won't be able to join today. So I did have Jazzy Custer, a FA, and Katrina Taylor, the charge nurse from Presidious Medical Care of Lebanon. So these are their slides. This is a little information about their facility. Next slide, please. Again, an introduction to themselves. So their influenza vaccination rates, they had 87% of their patients that were vaccinated as of February. 12% of patients had declined the vaccine, and they had 15 patients that were currently in an unknown status. The network recently hosted a important influenza call that focused around documentation and EQRS as well. They were on that call and they took the information provided to them to help them reconcile those 15 patients that had that unknown status. And they also had about 1% of patients who were pending admissions. And upon admissions, they again speak to their vaccination status. Next slide, please. So for their pneumonia vaccines, they had about 68% of their patients that had completed the pneumonia vaccination series. 10% of the patients are candidates that are due to be vaccinated. About 8% of the patients refused the vaccines, and 56% of the patients are in the progress of getting the vaccinations. Next slide, please. And for their hepatitis B, they had about 90% of the patients that had completed the Hep B vaccine in series or either were immune. 18% of their patients are in the progress, and 19% of the patients have refused the vaccines. Next slide, please. So they kind of were going to speak to their process. So this was the process that we communicated about when we discussed their facility and what they do to try to help increase their vaccination rates. They asked patients early into the admission process for their vaccination consents, making sure that patients were aware that they offered vaccines, and if the patients were willing to receive those vaccines, getting those consents as soon as possible. They had an RN designated as a vaccination champion for their facility, which is very important because usually those vaccination champions are the people who help facilitate those lobby days, who are working with PFRs to create those huddle boards so that they can have that communication out in the open for patients to receive. When patients decline vaccines, they wait a little while, about a week or two, and they follow up with the physician. And again, they educate. Education reinforcement is key. Making sure that they're aware with the most up-to-date information is always important. So it gives them an opportunity to really think it over. And they employ their patient care techs to reinforce patient education, and the importance of vaccinations amongst the ESRD population. I did have another facility who spoke about the same thing, making sure that their staff were educated in that education. Because if you have people who are promoting that pro-vaccination culture, but them themselves are not aware of what's going on, how important it is, what the up-to-date vaccination status looks like, then they're not giving the appropriate information to the patient. So maybe they're out of date, and maybe the information that they're speaking on, it doesn't pertain to that patient personally in their mind. So making sure that they're trained and they're well aware of what vaccinations are needed for the ESRD population and which ones are recommended for them, and delivering that message at the chair side is very important. Next slide, please. And I believe that is the end of their slides. And again, it was unfortunate that they are not available to continue to speak to that or answer any questions you guys may have. But definitely, if there are any questions, please put those in the chat and I will try to answer those to the best of my ability. Thank you. So I do see someone who said, can you explain again the vaccination champion? So this is someone within the facility who may be the lead when it comes to vaccines, vaccinations, the one that's making the patients aware of when the clinic is going to be administering vaccines. So it gives them an opportunity to be proactive and not reactive. They have the opportunity to think it over, discuss the information that's provided with any of their caretakers or family members. They're also the ones that probably work side by side with the social workers to get the information to the PFRs, to have those communication with the patients, the ones who help orchestrate the huddle boards, the lobby days, the vaccination clinics that some facilities have where they set a date and they make it basically a campaign, so that patients who aren't vaccinated, they have the opportunity to know what's coming down the pipeline. And again, they can have those conversations. Sometimes patients have to get that assurance from their caretakers or their family members or people who possibly receive those vaccines because of various barriers that we previously discussed. And so it gives them an opportunity to kind of take control of that and help build that pro-vaccination culture. So I have, what are some things that are done during lobby days? So examples of things that are done during lobby days, again, are the communication. We all know in the facilities how we campaign for influenza. Throughout the facility is always a big thing at a particular time of the year. It's very important. It's a push campaign almost for getting patients and staff vaccinated. So what they do is they promote this. This is what's going to happen. This is how we're going to facilitate it. This is how this is what the execution looks like. And then there is the actual completing it. This patients receiving vaccines, ensuring our consents are completed and accounted for, vaccines are received, information is entered in the appropriate place, either it be NHSN or EQRS, things of that nature. Not seeing any other questions at this time. I did see a question. I'm not sure if it was for the hospitalizations or the vaccinations about the PowerPoint. We will make this available in IPRO Learn. And here is the contact information for the vaccination speaker. I'm not sure if Lorna has her information on her slide, but if not, if she doesn't mind putting that into the chat, that'll be appreciated.
Hi, this is Debbie again, and I found some questions for Lorna, and she is still with us. And Lorna, there was a question placed in chat after you stopped talking, and I just noticed it. Is, do you have any recommendations of how to get in touch with the hospital case managers? That's a struggle for all of our facilities, and I just wondered if you had any input to that. I, for one, can say that with me trying to get in touch with hospital systems to try to work proactively to decrease emergency room visits and admissions, that I have had a terrible time trying to get in touch with them. And it really stems from the fact of a low staffing. Lorna, do you have any suggestions?
Um, I'm not seeing any more questions. I'm not sure if anyone else has anything for Lorna. Again, thank you for your participation and being here with us today. If no one has anything, I see that someone has their hand raised. Is there any way for you to put your comment or question in the chat? So there are a couple hands raised. If you don't mind putting your question in the chat. If we don't have any other questions or comments or anything, we can go ahead and we can end our call early today. Again, thank you for joining us. Always visit our IPRO Learn forum for interventions and resources to help assist in these efforts, and contact your project lead if you have any questions, comments, or concerns. Again, thank you.